So it's wonderful the diversity we have in the room today. And I've actually do work in Singapore and New Zealand. I've not done any work in Phoenix. So I know something about your countries, and I know that enough to say a lot of what we're talking about here today is true for you, and is true for everybody. So I'm Carol Haraden. I'm a vice president at the Institute for Healthcare Improvement. I work in patient safety and reliability. I just moved back from living in the UK for 4 years. I have active work with the Southwest Strategic Health Authority, Scotland, our friends in Denmark, in Singapore, Colombia, a bunch in the United States. So we get to see a lot of systems of care. And the good news is we're mostly alike. The bad news is we're mostly alike. Okay? We got both going on there. Okay. So today I'm going to be very provocative. Some of you know me. That will not surprise you. But I'm, as I said to our board yesterday, I'm 60 and I'm getting cranky. I'm almost 60. And I know that's hard to imagine, isn't it? I want to say that again. And I want you to act surprised. I'm almost 60. Thank you. I know. Shocking. I can't believe it myself. And my mother still thinks I'm 23, so that's a good thing, I guess. So I feel like I am getting cranky. I'm getting impatient. I've been working in this field for a long time, as have most of you. And we just have got to do better. We have got to do better. Oh, I wonder what that sound was. I'm always wondering, what do people's ringtones say about them? I'm not sure. That was an interesting one. But it isn't like the dance of the ballerina, which is much more suspicious. Okay. Personally, I'm looking for Volender on my phone. That's what I want. So I'm going to talk with you about some things I think are universal. I'm happy to have you challenge me, and then we'll talk together. So I'll leave time at the end for some questions. We are being recorded, so I will ask that if you have questions, you step up to one of the 3 strategically placed mics and ask your question. That would be great. And if you're at, or 4, I guess, so you're in good shape there. So, going to start with this. There are dates in our lives that all of us will remember. For those of us in the United States who were alive, the day Kennedy was assassinated and Martin Luther King, those are memories that are in our minds and will be in our minds probably forever. What we were doing at that moment, we found out. 9/11 is like that. It's in the national consciousness, and I think the worldwide consciousness. So there are sentinel dates in all of our lives that we remember. Well, this is a date of a surgery at Cincinnati Children's where a child died unnecessarily. And this is the day. And if you walk around Cincinnati Children's, you go around the world and you say 9/11, you typically don't have to do much explaining. If you go to Cincinnati Children's and say August 16th, 2011, everybody knows what you're talking about because a child died unnecessarily that day. And tragically, it was a minor surgery. So they had been working on patient safety diligently, and they're such good people, such an exemplar for us in many, many ways. Now, what happened is a piece of equipment got into the OR that nobody had really trained on or been checked out on. Okay? They've been working on a million things. That process, for whatever reason, it failed that day. And it was used improperly and the child died. Okay? So they talked to all the staff. They ran all kinds of sessions talking about that. There's all kinds of seats over here. Please feel free. Don't worry. Just come right over. I'm glad you're here. So it's been about 600 days since the last OR event. And they've had to climb out of that hole. How many of you do rare event measurement? Days between events. Yeah. So at some point, a rate is meaningless. It's not helpful to say, we have, or how would most people, your board, or even your staff, interpret, we have a surgical site infection rate of 0.006. I don't know, is that good? Seems little. Unless you're the one, of course, unless it's your family. It's a lot better when you get to rare events to start looking at days between events. Much more sensitive, and the fact is, much more traction with staff. So you're able to say, on every given day, it's posted. And those of you who are doing it, I think you're probably doing this. I know my colleagues in Scotland and Denmark are doing this. And that is, they post how many days since an event. So you're able, and you know, as soon as you have an event, what happens to that rate? It goes to 0. Do you know what it feels like to have 342 days from your last central line infection to walk in the next day and it's 0? Do you think that that escapes people's notice? Where if the rate changes from 006 to 0059 or 0063, do you think anyone notices? No, they do not. They do not. I'm a statistician. Even I don't notice. So I will tell you, the rare event measurement's very helpful. So they're using that, and if they have a surgical event, it's going to go right back to 0. So I was at Cincinnati Children's. We had IHI Strategic Partners has a thing called summer camp where all the strategic partners get together. This last summer it was in Cincinnati. Children's hosted it. This summer will be Denmark will be hosting it. So we, as part of our summer camp, doesn't it sound like it's... First time I heard it, I thought, that's all right. I was a counselor. I can swim, canoe, do all that. It's not about that. There's none of that going on at summer camp, it turns out. So we do make site visits. And in Cincinnati, I did the site visit at a company called Celanese, which is the safest company in the United States. And they make plastic... little plastic dots, essentially, that are made into bigger polymers, bigger buckets, or whatever you want to make plastic from. They make the little pegs, and then you melt them down, and it's the raw material for that. So again, it's a manufacturing firm. People, lots of moving parts, molten material, all kinds of opportunities for harm. But interesting, whether that's what they do or they make something else, it's immaterial. What I want to show to you is how different. Oh, I actually know how to use this if I don't mess it up. It's impossible to say you know how to use something and then say you might mess it up. Okay. So safety as a precondition. Now, isn't that interesting? So a lot of us in healthcare, safety is quite young, and when we're still celebrating our lack of failure. You know, all the people who came in never thought that was something to celebrate. They actually expected it. They don't come in and say, oh, I didn't get a surgical site infection. Isn't that great? They never expected to get a surgical site infection. But we're at that point now where we're crawling our way out of and learning our way into much better ways to do care. And because of that, and really accepting that defects are not inevitable. So safety for us is not yet a precondition. We're still working on this. This isn't the go-in proposition. You don't say to everybody coming into the hospital, one thing I can promise you is you won't have an adverse event. We're not there, right? No way. But we're trying, but this is what a mature system looks like. So I just want you to quickly look at some of these, and I'm going to ask you, of all of those in that triangle, which one sticks out the most to you? So I'm going to ask you to vote. So look at those and say, which one of these do I think surprises me the most, and probably in healthcare is the least well developed? Engaged leadership drive. Engaged leadership drives the process. How many people think that that's an issue in healthcare still? This is an audience participation moment. You just don't sit there. You're going to have to do something. You don't raise your hand now. You just get ready for later. Okay? So accountability metrics, where we know who's accountable and for what. Okay? How about employee... Whoops, see? I think I'm getting smart, getting ahead of myself here. Okay. So employee ownership. It's my responsibility. Yeah, big issue for us still. How about this one? Getting ahead of risk. Upgrade the system to see risk. Big issue for us. Big issue for us. You know, It's actually a truth that filling out that falls risk assessment form has never prevented a fall in your life. Amazing, isn't it? That piece of paper won't do a thing for you. You actually have to do something with it, turns out. You actually have to take that piece of paper and make some pretty serious changes based on what you learn. But we're so busy filling out our forms that we forgot that it's supposed to be a reflection of dynamic risk, not static risk, and what we need to do based on that form. So this continually upgrading. How about this next one? Continually redefine what good is. Are we there? Anyone here? So raise your hand if you think we're there. Continually redefine what good is. Oh, no. I'm glad none of you raised your hand. Really. We're still celebrating the lack of failure. We are not. So there's two kinds of safety, and any of you who haven't gone to Eric Holnagel's session, I would say you might want to if you're interested in safety. He's great. He talks about safety 1 and safety 2. Safety 1 is the removal of defects, pure and simple. Safety 2 is building reliability so that you deliver what you want to deliver. Right? So you want every patient who comes in with sepsis to get quickly, well, most likely you want them to be resuscitated with fluid. You want them to get antibiotics quickly. Okay? There are things that you want to be done reliably all the time. The lack of that is not necessarily an error. It may be your systems are not set up to deliver that. That is safety 2. Safety 1 is the removal of defects, and we're pretty squarely still in safety 1. We're doing some good work on safety 2. Okay? But right now, we're quite stuck there. Now, I will tell you, this is a little anecdote. I was sitting with a group of CEOs from a system I'm working with in the United States, and it was our first meeting together. And I said, what do you think is going to be your biggest barrier to succeeding in this program? And they thought and they talked, and one raised his hand, but they all concurred. He said, we're already really good. And I said this, and I swear to God I did. I've seen your data, and you're not that good. But here's the thing. He said, we won the award for the best hospital. Yeah, you did. You know what? Who is your competition? So it's easy to start developing a mythology about who you are and to start believing it. So when you look at their data, they were good within their cohort. And how many of us look at ourselves against a set cohort instead of what is the best practice out there? And you know, when you're good within your own cohort, you know what we call that? Vivica, what do we call that? Cream of the crap. Cream of the crap. Okay? So I used to do this. I used to bring my big old data into my CEO. I was Vice President for Quality and Systems Improvement. And I brought it in, and he'd say, Carol, how are we doing? And I'd say, good. Because I measured ourselves against academic medical centers in the Northeast of America. And according to that benchmark, we were. What was he asking when he said, how are we doing? What do you think? Was he saying, how are we doing against the best? What do you think? Compared to the average. Am I in danger of being embarrassed? Is my head above the parapet? Are the reporters coming tomorrow? Is my head above the parapet? Or am I safely within the group I measured against? Now, the interesting thing is that it's an appropriate group for size and demography and risk. All those things are true, but we couldn't learn from it. We couldn't learn and improve from it because we were right smack there with the rest of us breaking our arm and patting ourselves on the back. We did not continually redefine what good is. Good would be, hey, let's get where our own demographic is, with our own exemplar groups, let's get there. And then, I felt good about this until one day I read an article from Intermountain Health, and they were, I think, about 60% better than we were in infection rates. Big time. Huge. And then when I went in and talked to the CEO, and he said, "How are we doing?" I had to say, "Not so good." Oh, uh-oh, hadn't heard that from me before. What does that mean? And I said, well, what it means is our rate is here in our cohort. Phew, okay, now I can sleep tonight. Now what else do you have to say? But here we are against the best in class. Oh, but we'll find a million reasons. The best in class is in Utah. The best in class is a bigger hospital than we are, although we're both tertiary. In fact, quaternary centers. We all both did transplants, et cetera, et cetera. How many of you or how many of your colleagues, when confronted with a harsh reality, say exactly the same thing? Oh my, that's them. It's a different state, it's a different region, it's a different country, it's a different shift. It's a different unit within our own hospital. We will find a million ways to slice and dice. And I had this happen to me just recently. And I was presenting some really good data. So I was visiting. Anyone here from South Africa? Great. So I was visiting a poor hospital right outside the township, outside Cape Town. And I was watching, a surgeon was bringing me around. And I said to him, just thinking about care, "What's your catheter-associated infection rate, urinary catheter-associated infection rate?" He said 0. Now, I've heard that before. Serious doubt kicks in. But I've learned not to say liar. That doesn't go over. So what I usually say is this: "Wow, that surprises me, say more." And he said, "We take them out in the recovery room. We need that bed. We need them to get up and get going quickly. We do not leave them in." Well, that's right. They do have 0. Because if it ain't in, you ain't getting infected. Well, I bring it back, and I say, "Isn't this amazing?" Now, granted, maybe we can't get to 0, but we sure as heck could do a lot better than we're doing. So I presented it to my friends, and they all immediately said, "Oh, ridiculous." Blah, blah, blah. And I said, "Do you call yourself scientists?" Absolutely. Where is your curiosity? Curiosity is the hallmark of a scientist. You have not even once said to me, "Really, what kind of hospital? What did they do? Were they at least collect some data from me before you dismiss it out of hand?" So this continually define what good is something we need to do. We have not done. We rest on our laurels. We often are part of cream of the crop. We are overly satisfied with subpar performance. And I'm not speaking to you individually. I don't know you all. But I know some of you. Okay. And you know who you are, who I know. You know I know you. Okay. So here's what I find when I go around hospitals now. So some of you know who are in fetal medicine, maternal fetal medicine, when you're reading a strip and you're interpreting fetal monitoring, you typically say one or two things. Now, I am reassured or I am not reassured. And if you're reassured, that means the child is doing, the fetus is doing what it should, and the mother. And when you don't see that, then you have to make some decisions and have a discussion. So I love that. When I walk around, I say, am I reassured by what I see, or am I not reassured? Am I reassured we're going in the right direction? Am I reassured that the care is what it could be? Am I reassured we're working hard? So when I look at that, I am reassured by what? I'll show you. Next slide, please. I am reassured by the level of safe and reliable care in some places, at some times of the day, some days of the week, for patients with certain conditions when cared for by certain clinicians. Is that not true? If it were, you would never have any preference about who your child was going to see when they were sick, because they'd all be equal. You wouldn't care which unit they went on, because they'd all be equal. And the epitome of safety is what we call equivalent actors. Like when you go on a plane, you don't say, "May I see your graduation from aviation school certificate?" or your recent flight history. You assume equivalency, that all pilots will be safe. You don't have to like them all, but they are all safe. We do not assume equivalency in healthcare. We don't assume it at nurses level, at the pharmacy level, at any level. There is no equivalency. You know, this is a big surprise to the public, I have to tell you. They actually think all of us are competent. And all of us are doing exactly what we need to do. So this notion of random, or rather not random, it is random actually, rampant variability is not a hallmark of a profession that's going to succeed. So a couple things that I'm going to obsess about here today. One is this notion of we have no learning system. What happened in Operating Theater 1 could happen in Operating Theater 20 next week. We do not even learn within our own organizations. And I know this because I ask this. And again, this is broad sweeping statements. There may be many of you who have, well, no, I take that back. There'll be some of you who might do better. I don't think there's many of us. And we're all in this together. So I always ask this. How many of you measure how many root cause analyses you do? Really, that's it? Most people measure. Is this, we're not sure? Or how many of you measure root cause analyses? Okay, eighth of the room. How many of you measure when a bad event happens post a root cause analysis? Okay, we got 3, 4. And that is the hallmark of a learning system. Because we're happy to do root cause analyses till the cows come home. Bad event, root cause. And there's no amount of money we will throw at this thing once it's happened. We'll pull surgeons out of surgery, and we'll pull risk managers in. We'll pull the staff in. We'll debrief them for hours. We'll write it up. However, how about we learn from the one that happened down the street or 3 ORs away? Where is the learning system that says, everybody, this has just happened, and we need to be sure it's not going to happen to you. Could you quickly check your systems, and we'll be around to see how we can help you? Would it be acceptable to us in the airplane industry if an engine falls out of a wing in a Boeing 747 and they didn't check the rest? Terrible thing for those folks, but you know. That they didn't immediately go out and check the rest. Isn't it interesting, the rules we have for other industries? But when something bad happens, do we run and find out, could that happen to us someplace else? How do we know? We don't. We're really quite bereft of a learning system. A really robust learning system. Policies and procedures and clinical guidelines. I would say, broad brush, you've all got between 300 and 500 policies and procedures? Anyone want to dispute that? People got less than 200. Anyone less than 200? Anyone less than 300? It's like an auction. Less than 300? Okay, no one's got less than 300. How's that working for you, that policy and procedure thing? How's that going for you? Because here's what I hear. Of the 400 or 300 that you've got, about 5 are helpful. I've never heard more than 10. Never. And I do this little exercise all over the world. Never hear more than 10. And yet, when we have a clinical issue to improve, what's the next thing we'll do? We will write a policy and procedure because the last 462 weren't enough. What did Einstein say? The definition of insanity is what? Doing the same thing and expecting different results. So all of those policies and procedures are the best little dust collector you have ever had. Can you imagine being a staff member and saying, I have to help with an emergency tracheotomy, or I have to help put in a chest tube. Let me go and read the policy. First of all, kick someone off the computer. You've got to find a computer terminal, and then you've got to use some God knows arcane system to figure out what the person who filed this called it. Am I not right? I am right. It's completely unusable. And then you've got to read. How many pages do you think? I checked. I've checked 3 places now. I know that's not a huge sample. Even a statistician knows that. So how many pages do you think the instructions are to put in a chest tube? How long's that policy? Oh, You dreamer. 10. 36. The average was 36 pages. 36. Policy and procedure, remember. You've got to have both. You've got to have the real long-winded policy, and you've got to have the real long-winded procedure. Useless to the person at the front line. So how many of you would feel all right if we were having this conversation with nuclear power and we said, how about those policies and procedures? Oh, yeah, well, we never use those. Filed away, can't get to them. What would you do? Would you be alarmed? And yet, we are suffering so acutely from the boiled frog syndrome in healthcare. Do you know the boiled frog syndrome? You throw a frog, put a frog in cold water, and you raise the temperature slowly and they boil to death. If you throw a frog in hot water, they will attempt to get out. But we are slowly raising the temperature. And we don't even see that we have an unusable learning system that is not helping our front line at all. And yet we will write more. And why will we do that? What are all those policies and procedures for? Accreditation. There you go. There's one, accreditation, and shame on them for just accepting that. That's right, not you. But to come in and just say, show me all your policies and procedures without saying, and by the way, how do you make these work? And I'm going to take this stopwatch and I'm going to go up to your unit. This is why I'll never ask to be on an accreditation team, which is fine with me, by the way. So I'm going to take this here stopwatch and I'm going to give a clinician a problem they have to solve quickly, and I'm going to time how long it takes them to find that policy and procedure, read it, and use it. Instead, we just measure, I think, a scale would be a better measure, wouldn't it? Just come and weigh them all. Because it can weigh a lot. Weigh a lot. So, accreditation, why else? You bet. CYA. When someone goes to court, they'll say, do you have a policy and procedure? This is also why I have literally never gotten on a jury. Because my next question will be what? Was it usable? I don't care if you got a policy. I think you're more damned by having one that's unusable, frankly. I'd rather you say we didn't know. I might have some sympathy on you. But you got one and you can't use it. Why do we think that's protecting us? I keep looking for the answer, like it just hasn't come to me yet, but I haven't found it. Okay, clinical data. Reasons I'm worried. Staff leadership often do not have current data on the safety and reliability of the clinical processes to inform their daily decision-making. So data is presented quarterly or monthly, rolled up. How many of you can remember what you had for breakfast today? I'm really not sure. Really, I would have to think for a moment. I've been in a lot of hotels. I tried to break into someone else's room yesterday. Because that room number was the same one I had before I got here. And I've done that before and had someone answer and say, may I help you? I don't look too threatening, hopefully. They don't know me. So I look at the data. So when I do assessments for hospitals, they ask me to come in, take a look at their safety system. I'll say, show me your data. So I want to see it at the leadership level. Then I go down to the mid-managers and say, show me your data. Then I go down to the front line and say, show me your data. And the leadership usually has some. It's quite old. It's rolled up. Okay. Now, mid-managers? Maybe. For a month. What can you tell about an infection rate on your unit in a month? Where was the problem? Would you have any idea? What shift? What day? What weekend? What variation? Would you have any? No, you would not. So how do frontline providers improve their care if they don't have the data that drives them to improve? So one of the things that we do, and I love this approach, is we say every day collect 5. So maybe I've got 5 staff on today and they're really busy, so I might not ask each of them to collect 5 pieces of data. I might ask them to each collect 3. But I still, at the end of that shift, have how many pieces of data? It's a math test. Are you awake? 15, that's right. 15 pieces of data. Okay, so I've got 15. So at the end of the day, I can literally say, all right, where are we? So you put yours down. You're 2 out of 3. You're 3 out of 3. You're 1 out of 3. At the end of the day, I add those things up and I say we're 60% or 70 or 100. But I have feedback on how we did. Now, do I think that's statistically significant? No, I do not. Do I think it's enough over time to tell us? If you're supposed to be 100% and you're at 60, do I need more data? Nothing you do is going to make that 100. It's not. So people will say, well, you need more data. No, you don't. It might not be 60. Maybe it's 72. Maybe it's 50. I don't know, but it sure as heck ain't 100. And that's where you're supposed to be. So why are we quibbling while Rome is burning? Can we not start where we are and start to fix this without perfect data? We know we're not doing what we need to do, and it could help us. So at the end of the day, we say to our staff, hey, here's where we are. What happened today? And sometimes it's real good. We learn so much. We had a locum. We had a code. Isn't it funny? I find this paradoxical. So on days when we're most busy and we're most stressed is when we give up the most safety work. We don't have time for it. So would you say we're less safe today? Oh, yeah. So it's a good time to give up all those safety. Oh, yeah. You know, that's when you make the decision, what's the minimal thing we have to do today to be safe? And it isn't business as usual and cut out all the safety safeguards. Okay, how many of you are feeling sleepy? Stand up. Just stand up. I see a few of you. Stand up. Shake yourself out a little bit. It's late in the day. This is not an invitation to leave the room. Okay, have a seat. Have a seat. Thank you very much. Okay, I have forestalled the inevitable for yet another 10 minutes. Okay, so this data piece, if you don't have the front line collecting, and what's it feel like? How many of you have been the beneficiary of the data collector's largesse? And they come and they collect data for you and give it back to you. And you look at it and you say, what? I'm not really. Did the lights just change or was it me? Did they? Thank you. Never really quite sure. I'm having a little TIA up here or something's happening. Okay, so here you are. You've got this data, and one of the first things you say is, they don't understand our systems, they didn't collect our data right, blah, 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 blah. When your staff is collecting their own data, it's irrefutable. You get two benefits. They both collect data, and secondly, they get to see their own processes. There's no question at the end of the day. You don't need to say, because if you ask, this is, I think, a point, who made this point? Oh, it was in Lynn Maher's session. If you say, excuse me, Bart, have you done these 3 processes today? Have you measured your patient's vital signs and completed the early warning scoring system on your patients? What are you going to say, Bart? Oh, don't be honest. I mean, be honest. Don't be. You'll say, of course I have. And if I ask you, and often you think you have. So there's no point asking people because we overestimate. We overestimate our performance. So don't ask. There's no point. And all of us are self-deluded in some areas of our life. Every one of us. So there's no point asking, just go out and look. And don't do this. Think you did, huh? I got the data here. Well, that's just a killer, right? You don't do that. You simply say, we didn't. This is what, I love this with children. There's water on the floor in a broken glass, and you say to Johnny, did you do that? Would you think a ghost was here? Of course he didn't. Don't ask questions, just say, how'd that happen? Anyway, same thing here. Don't ask questions when you know the obvious. Okay, so reliability. The issue of reliable for us is we know, we can tell you what's going on. And we know we have some control of the process. Dynamic because it happens all the time. So safety is a dynamic non-event. Isn't that funny? Safety is a dynamic non-event. Nobody's calling up infection control today and just calling you to tell you we got no infections. No one's doing that. But that's what safety is. And when that happens, the non-event often looks like it becomes normalcy, but it doesn't claim attention. Because we're used to things happening. And the silence and quiescence of a safe place is that nothing's happening. And that just seems strange to us. Okay? That actually becomes very strange until you get into really good systems. However, unless you're working at the process level, no event we think is safety, and we think that's excellent. The problem is this: when you have random and rare events, you can have long periods of quiet between events, which we all read as safety or improvement. It's really just the time bomb ticking for the next bad thing to happen. So unless you have process level data, so here's what I mean. I often have leadership come around, and most of us are interested in outcomes. We'll say, what's your outcomes? What's your outcomes? You know, I don't care about your outcomes if you haven't got a reliable process that drives them. No outcome improves without a reliable process behind it. Okay? They don't. They don't just up and improve themselves. You want an outcome better, you make the process that drives it more reliable. So if I come to you and you say that we have, what's that outcome you're interested in? What's an outcome, clinical outcome you're interested in? Oh, you would pick that one. Falls prevention. Okay, so interesting. Falls prevention. If you tell me we have not had a fall for the last month, a single fall, what's the next thing out of my mouth? Really? What's the process that created that? We don't know. Well, you know what? Then you ain't got no falls. I don't believe you. I really don't. That kind of change, someone had to do some work. Okay? So either you're blind or it's not happening. I just don't believe it. So if you tell me you've had no falls and I say to you, tell me what you've done to create that situation, that's great. You can say, well, this is how we started. And then we did this, and then we did that. Now, every one of those, and hopefully that's on an annotated run chart, and I get where I believe it more and more and more. Because I can see where you are. I can see how you've dug yourself out of that and all the changes you've made. If you can't share that with me and show me that you're doing maybe daily rounds for patients or you're doing rounds 4 times a day, I don't know. But if you can't tell me you've got a tried and true intervention that's reliable, how could it produce that outcome? So we should be obsessing about processes. Obsessing about processes. The outcomes, of course, the outcomes tell us at the end of the day, you can have great process level data and have no outcomes. And usually it's not true, you really don't have reliable process level data, we just think we do. So this notion of our time where there's quiescence or a quiet period, we often think we're safe, but really without good processes to stand behind, it's just a waiting game. That's all. We need to know that. Okay. So, another way, now when I start to think about how we could get better, how we can get better, this notion of adaptability and resilience is key. It is going to save us, and segmentation, I think, in the next 10 years are going to be so important to us. This notion of standardizing that which is standardizable and nothing more, because there may be variability, and you need to know that. So when you put standards out, you say this. Here is a standard. We've worked on it. We've tested it. We know it works. But if you have any doubt that this will harm your patient or not work for your patient, you must not use it. You must, however, tell me why. You have to make a note why. Why is that important, that tell me why? Why is that critical? It's a learning system. You haven't got a learning system if you don't have it. So you don't use it with certain patients and you don't use it with certain patients. And if you tell me that, sometimes we've uncovered segments of the population we didn't know existed because we learn you've got 20 patients you're treating with anticoagulation. And you say, oh, I can't put this patient on this nomogram or algorithm because of X. And you just go your merry way, but the system doesn't get any smarter. You get smarter. You do the same, you do the same, you do the same. System doesn't get any smarter, you get smarter. Unfortunately, if you were to send all that information in, I don't use it on this patient, and here's why, then we could rewrite this and say, hey, here's a group of patients for whom you should be very careful in using this, or not at all. And then everybody gets smarter. We call this a tyranny of small numbers. For any individual clinician, they will see very little big harm this year. But I'm looking at all of you, and I see big harm. Because for you, you're creating 2 or 3 apiece a year, and I've got 50 of you. And I just saw 150 bad events. However, when I bring this up to you, you're thinking, what are you going on about, Carol? I've hardly seen anything. I've got 1,000 other things I should be working on. I don't have problems with anticoagulation. But you know what? We do. As a system, we do. So I'm looking at system-level data. You're looking at individual data. And we're having a dialogue of the deaf. Totally unwilling to enter each other's reality of, I bet this feels like not important to you, and I know why. And I bet you think the same of me, but let me share with you the data we have at the system. And it tells me we've got way too many patients being harmed, and we've got to learn our way out of this in a different way. So this notion of insisting on discussion and learning is key. If you have a standardization system that doesn't include that, doesn't allow clinicians to opt out when they think patients are going to be harmed, that's why they won't standardize to start with. Because they think you're taking decision-making out of their hands. And you can never do that for any clinician. Doctors, nurses, pharmacists, they have to be the final arbiter. However, we all know there are best practices out there, and we should be using them when we can. Okay? So this notion of adaptation is so important. So I was talking to a clinician in the ED, emergency department, and I said, what do you think about standardization? He said, I think it's overrated. I think it's, we've got a lot of, patients are all different, and so forth and so on. So what I did is I followed him around. I said, do I have your permission to follow you around for a shift? Yes, you do. I literally followed him around for a shift, and that man had 100 standards, but they were all his. Do you think every time he saw a patient, he said, oh my goodness, a patient with a fever, what shall I do? I need to think out of the box. And of course not, he has a way to do that, right? Don't you all? Have heuristics you use every day? Can you imagine how exhausting it would be if every day you got up and you thought, the sun is rising, what shall I do? You know to brush your teeth and start the car and put on your clothes, and these are automatic behaviors that serve you. It would be exhausting to think of that stuff all day long. And they have the same. So they absolutely have standards. They just have their own. Well, and when you got 20 of them, and it just ain't working for us. So don't tell me we don't have standardization. We absolutely do. It's just that we want it to be our standardization and nobody else's. So when I talk about variability, we want variability that adds value. I do not want no variability. You cannot have the same standard of care for every single patient. Impossible. But you shouldn't even write a standard unless you're at probably 80% of the patients fit that standard, or else you're just constantly dealing with variability all the time. Okay? So we want variability that adds value. It's based on expert judgment. It keeps us safe in novel situations. We do like the myth of the hero, though. Remember the pilot who landed on the plane on the Hudson? Sully Sullenberger. Well, no, thank you, Madge. I was searching for that name in my memory bank. It wasn't coming up. So when in all the interviews with him, we wanted to laud him as a hero. And the first thing he said on his first interview is, you know what's a hero is the designer of this plane. That was the hero. Because if that plane was not made to float and to land, we'd all be dead, no matter what I did. But we love the myth of the personal. Okay. So the other thing is, why was he able to do that? He had just been in the simulator within the month and had to simulate a water landing. Again, standardization, that's their standard training protocol. So we think personal hero, but it was just the accumulation of standards that got him to that point. And he's a smart guy, and he was calm. But in part because he'd been through the simulator with disaster after disaster. So do I want to take anything away from him? No, I don't. And if I'd been on it or someone I loved, I would be worshiping at his feet. I will tell you, though, that he would not allow that. He thinks that's ridiculous. That we do not understand really the problem and how to fix it if all we do is to say, what a brilliant pilot. It negates all of the resilient engineering that's gone on to get that situation where it is today. So the myth of the individual is pretty much a myth. Okay, so how am I doing here? I got 10 minutes? Is that right? Okay, thank you. I was looking for a response there, yeah. Okay. Is that right? All right. So some questions worth asking. When you're walking around your organization, these are some questions I always ask. Probably will never be asked to your organizations and after this, but when you walk around, I always ask these questions. I ask these of staff, and you would not believe how much they'll disclose to you. Because you're talking about a hypothetical situation that they've been in, not did this happen to you today and what did you do about it. But I ask this. Have you ever been in a situation where you could not follow a policy and procedure designed to make care safe? And every time they say yes, and they can tell you the story. And it's, you got to buckle up. You've got to take antacid that morning because maybe an antidepressant. The stories are shocking, scary. Okay? There's a lot going on out there. The amazing thing is that how well they do with just jiggering it up. But we can't rely on that. We're getting too complex to rely on one smart person figuring it out. Have you ever been in a situation where you had, do you know what I mean by off-service? Okay, outliers, a patient on a unit for which the care was not designed for them? Orthopedic patient on neurology. You know what I mean? What do you call them? Outliers. Okay, we call them off-service. They're not on the service intended. Outliers. Anyone else? Satellites. Borders. Yeah, borders is a big one. Borders is a big one. Do you know in the UK what the juniors, well, maybe not only the juniors, I have a consultant here with me, who has to go look for their patients on other units. You know what they call that? Going on safari. And they say it like, if you haven't been there, you say, what? But they talk about it like it's just common nomenclature, going on safari. To find our patients. So if we think for a moment those off-service patients get the same care as those on the cardiology unit when there are cardiology patients on another unit, do any of us really believe that's the same standard of care? Because if it is, why do we have units at all? Just have them come in and have a bed anywhere. Really? If it made no difference, why wouldn't we? Of course it makes a difference. So my question to you is, what is the safety system you have in place when you have patients not on a unit designed to care for them? You know what? Hope is the plan. I hope, ask the staff, hope we get through today. Hope I remember. And you know what? That is no promise to our patients or our staff who leave every day worried that they will be asked to care for somebody they don't know how to care for today. And they are scared. They come to work scared. That's terrible. So I'm not suggesting to you you'll never have outliers or borders. You will. It's the system you put in place to manage that. And it can't be, we just don't have enough staff. That isn't an answer. There are actually places that are doing a pretty good job with this, with the staff they have. But you have to ask yourself, the situation has to become unacceptable before you'll seek a solution. If it's acceptable, why would you seek a solution to a problem you don't see as a problem? So the first thing is to say, wow, yeah, okay. I've only seen one study and it's unpublished, but mortality rates for off-service patients were a third higher, 33% higher. And when I share that, nobody is surprised. Nobody says, oh, that's impossible. Everyone looks like, yeah. Yeah, unless it's your mother. That's not going to be okay. So really, these are the kinds of things that when I say constantly redefine what good is, this is what we have to take on. And the good news is we can. There are solutions out there, but we have to say we have a problem first. So how many of you know about migrations to boundaries. This is Rene Almaberti's work. He may be at the conference. He's fantastic. We usually teach at this conference together. So what he's saying is this. This is really a profound piece. He's saying that individuals, there's this thing called the safe space of action as designed by professional standards. And people will migrate away from that. So just like you who don't drive the speed limit, right? How many of you go exactly the speed limit, would never go over? None of you. And yet that is the accepted safe space of action on the highway. And you migrate over to what you call the usual space of action. We then actually think for us it's normal, but it's illegal. We're operating in an illegal normal space, and so do our staff. And partly they do it because they cannot get their work done in the space that they have, so they migrate. The sad thing is sometimes they tip right over into another space, and then an accident happens. And an accident happens. And this happens a lot, and you ask people, how did this happen? And you find, if you go back, a series of small migrations. A big decision often was not made. I guess I will just flagrantly disregard the safety. What happens is little small leaks in that balloon, and then it bursts, and a big bad thing happens. Okay. I'm going to stop there because I want to hear from questions from you. If you see the slides, I think I've got 2 more on there. But I think it's much more important that you have an opportunity to ask questions. So thank you very much. It's been great to be with you. Questions, thoughts, concerns? Martha.
Carol, as you well know, we are colleagues. We have never presented together. This is the first time I've seen you. For those of you who are here, I am the staff patient. I am the patient on board at IHI. I have not been this activated, upset, or clear about anything as I am now, because I understand why they haven't let you and I present together. First of all, most of the presentations that I do, and I present all over the world to organizations that are looking to engage patients. And so I'm always speaking from that place. Mm-hmm. I have never heard a more honest presentation on where things stand. And I am so shocked, and I am so concerned, and I am so determined to change the system. And shame on everyone here and everyone in the health system who isn't driven to do the exact same thing. Because you have shown me...
we're preaching to the converted. They came here.
No, and I know that.
Yeah.
But there is no time.
Yeah.
Because each of these individuals that you're talking about are me.
Yeah.
They are me. They are my friends. They are your friends, your family, and there's no reason for it.
Yeah.
I just needed to say that. So thank you for this presentation.
Certainly. I'd like us all to get a little crankier about it, to be honest. I'd like us all to get a little bit more impatient than we are right now. Okay, any other questions, thoughts, concerns? Yes, please. I know sometimes it's a bother to go, but I appreciate you doing it because it's being taped.
I'm Peter Barner of the regional, Central Denmark region. Thanks you for a very deep-felt presentation. I think that most people here know a lot or can identify with what you are saying. To speak for my own little Hassan with the short legs, as we could say in Danish, in Denmark we have a national accreditation system who works along the lines that you have set out here. The stage 1 is, do you have your policies and procedures? And stage 2 is, do you follow them? Do you work by them? And from personal experience, I can tell you that the surveyors do try to do what you tried. It's all in its very beginning.
Well, they're starting in a good place.
Yeah. But what I lack in your presentation is which 2, 3 actions should I take when I return to my country on Tuesday? What can I change in my system?
Okay.
We have legal systems that compel us to do incident reporting. We know that we are no way near a situation.
So here's rule 1: don't spend any more time on your incident reporting system.
Yeah, but then
you can only give you so much.
Then we have a legal action against us.
Well, As I say, I didn't say don't report. I said don't spend any more time fine-tuning it and buying an electronic one or anything else. Really, it's only going to give you a pinpoint. So I'm going to ask you a question. What is your sphere of influence? What's your job?
Yeah, I'm a regional risk manager, meaning that I'm not...
Oh! You were the one who needed a heartburn medication.
So what I should do is
yes.
I should go back and quit my job.
No, but you should start asking the hard questions.
Yeah.
You should start asking the hard, because if they're trained to say yes to you, which if they're smart people. If there's a problem for saying no, I'm going to say no. If you make it easy for me to tell you the truth, I will. And then we'll have to decide what to do about that. But truth-telling has to happen. Yeah. So there's one. The other is you start talking to staff and asking difficult questions and asking them, what can we do about this? Because they will know a lot of the answer, but we have to ask. So we have to say, how might we develop the policy and procedure that will help you? For me, I want those 36 pages. I want them on. I want you a one-pager with the ones that I absolutely have to do not to kill this patient.
Yeah.
I do not. 36 pages not going to help me. You could do that, and that would make a huge. You could start working on a learning system.
Critic, and we've heard in other presentations in this conference. People talking about involving frontline staff.
Right.
So obviously this is...
You can do that. You could start a learning system where you're saying, hey, let's figure out how we are learning from one another for risk management. That's perfect.
That was what the
legislators... There's so much stuff you could do.
That was what the legislators told us when they made the incident reporting system, that we should learn from it. We know the difficulties, obviously.
Yeah, we do. We do. Big difficulties. It's one piece, isn't it? It's not the learning system, it's a part of the learning system. Yeah. Other questions, thoughts, concerns? Thank you. That was excellent observation. Yes.
Good afternoon. My name is Victor Roggeveen. I'm a safety engineer who grew up in the oil and gas industry. And I'll not recall the Mexican Gulf or something like that. But in the industry, it's sort of common knowledge that things change after disasters. Mm-hmm. I think the problem in healthcare is that there are no disasters. In my little country, which
well, we kill them one at a time.
That's the point.
For the family, it's a disaster, but we're not killing 50 at once.
This is exactly the situation.
Yeah, that is the problem.
If a plane drops with 200 people in it, it's world news.
Right.
We have 2,000 fatalities by medical mistakes in my little country, the Netherlands, with 16 million people, 100 hospitals. 2,000, 100 hospitals, no problem. Right.
Because it's onesie-twosies.
That's what it is. So I'm very supportive of your presentation. I did this presentation, and it's not about me, but it's about the industry I am from. Yep. This presentation was done about 20 years ago in the industry.
Yeah.
Why?
Why
don't the healthcare industry doesn't connect? Why don't you learn from our mistakes? And why?
Well, because we like to say we're not building airplanes. Because we think, we believe that variability is inherent in our processes. That's why. Because variability should come from the patient, not the clinician. So if you're about to make a change, you've got a protocol, and you're going to use it for this patient and not for Vibeke, then what you should say is this. Okay, there's something Vibeke is presenting in a way that makes me anxious. Not, that's the way I like to do business. I don't care. The variation comes from her. And the reason I don't use that protocol is because of her and how she's presenting to me, not because I have a favorite way to do business. Variation comes from the patient, not the provider. That's value-added variation. It's value-added because you're treating the patient how they need to be treated, not how you want to do it yourself. That's very different. So whenever we have variation, so I think there is a belief, and we're slowly getting there, we are, that variation is inherent and there's nothing we can do about it, and maybe it's even a value. I don't know. But we have to get beyond that. You have to go to the mic if you want to speak.
Then I have
one more thing, and then
yes, one more thing.
Sure.
Is there, what is the nucleus recommendation that you could give hospitals, because the problem you address is a global problem?
Oh, you know, I love when people say, give me one. I just can't. I mean, I guess the number one thing I would say, honestly, is get out there and learn what's really happening and get the reality, because without the reality, you cannot move forward. So know what's happening, face it, and say, that's okay. I like to know what's going on. It's great to know what's going on. Now I can fix the problem. So really investigate where you are and get a learning system. But and even that, I got 10 other things. And so do you if I asked you. The answer lies in this room. There's nothing I can tell you that you don't, some number of people here don't know, and maybe even do. Yes?
I would just have a quick response to the gentleman who
yes.
We're from the same country. You tell us we have now disasters. Each year, 1,700 avoidable deaths in Holland. You call
that's what
that
he
no
said.
Disaster?
No,
okay.
That's what he said.
Yeah.
But he said we don't recognize it as a disaster because we're killing them one at a time.
Well, we don't. No, but we know there are 1,700 avoidable deaths
yes.
in Holland
yes.
each year.
Yes.
But I think nobody wants to know about it.
Yeah.
That's the problem.
I think we feel paralyzed. And it is
yeah.
extremely difficult. What's the point in telling somebody they have a big problem if there's no hope of fixing it? Yeah. So that's why we feel paralyzed. But there is hope. There are things we can do. Every one of us. There's great hope. I mean, I get to see the good, the bad, and the ugly. And there's lots of good out there. Yeah. There's just not, we're still on our journey, that's all. But it doesn't even start unless we say what we currently have is unacceptable. Yeah. Yes?
Hi, I'm Lynn Gallant. I'm from Anchorage, Alaska, and I work in a neonatal. I work as a frontline person. So there you go, a nurse. Anyway, we actually...
How'd you sneak in here?
I know. I'm also the unit safety coordinator. So unlike most frontline people, I am aware of like what the monthly infection rates are and all of that because I see all of the unusual occurrence reports. However...
That aren't so unusual.
That aren't so unusual.
Yeah.
Unfortunately, our unit as its own entity is actually quite... we're kind of one of the safer units of the hospital in terms of we measure ourselves against an international network. We collaborate
Vermont, Oxford.
with, right, we're in Vermont, Oxford. We are within a collaborative within that.
Yeah.
Of 7 other units. So we're doing a lot of like improvement work.
Right.
However, the rest of the hospital
well, careful. You got things you got to work on too.
Right. I'm not saying that we're perfect.
You don't want to go there.
I'm not saying that we're perfect.
Okay. Yeah.
However, and this is where we are from like a staff person perspective, is that you never feel like the rest of the hospital or the upper management has any interest or any buy-in to what you as a frontline person are doing on a day-to-day basis.
So let me give you a little dialogue that when some of you in here have gone to the Patient Safety Officer program. So here's the dialogue we rehearse. How many people, when the phone rings at the CEO's office, how often is it good news? People just calling you to say everything's working great today. Doesn't happen. Doesn't happen. So how do we train ourselves? And I mean this seriously, because we all fall into this, myself included. How do we become an answer to a problem they've got? So we call up and we say, really, I know you need good news stories. I know you'd like to see things working. We have them here. We'd love to have you come up and let us tell you about it. So we want them always to be reaching out to us. They're one person. They've got a huge panoply of problems to work on. And they should be interested. I'm not saying they aren't. But by golly, if they're not, I'm going to woo them into it. So then I always say, I think I've got an answer to a problem. You know that falls, that pressure ulcer problem we've got? I think I've got an answer to it on my unit. And all I need is a little bit of this to spread it. So I always make the ask small and after I've told them all the good news. Because really, I'm telling you, that works. Beating them up and saying you're not interested, you never come, you never ask, gets us nowhere, and yet I know where you're coming from. You are frustrated, and many people share that. It's also true that he needs or she needs to hear you. They need to know your good news. and they will want to hear it. And then you have to say, how can I help the rest of this organization without it being overly burdensome to you? You have a legitimate job, but what could I do? What are we learning in this unit that was transferable to other places? At the very least, let's document that. We can't go to every unit, but we could say, hey, here's what's keeping us safe, and what can you do to spread that? And not die under the weight of it. But I challenge you to be an answer to the problem your senior team has, because you are. You clearly are. You've got passion for this work. You've got knowledge. And offer it up, because no one is calling them and offering it up. Trust me. Okay. So you could be such a help to that organization. And you don't want to die under the weight of it. You just got to match that. But really, you could be. You really could be. Yes. Yes.
Patty Webster. Hi, I'm with IHI. I'm an improvement advisor. My heart is literally pounding because this was phenomenal. My husband is going in for surgery on Monday, so I'm petrified now. So as a family member, I appreciate the honesty, and I think this was wonderful. I think everyone here I heard cheers and excitement and nervousness, but most of all, the comments that you're making about variability and patience, I think are spot on to what a lot of people need to hear. Your analogy of equivalent actors in the aviation industry. I think sometimes people assume that patients are all equivalent.
Yeah.
And family members are, and they're not. So I really applaud you for bringing that up. They're also a phenomenal resource in terms of helping improve patient safety.
Sure.
And I haven't heard you, I know that you've got a vast amount of knowledge on this, but can you share on a positive note how patients and family members have been active involvement and active engagers in improving this and being part of the solution?
So I guess, and any of you have to go, please. I'm running over. I won't. Obviously, you need to do what you need to do completely. Don't feel, they're thinking, we didn't feel bad. What's she saying that for? So the thing about patients, Patty, it's a two-edged sword. We cannot make them responsible for their safety, their own safety in the hospital. That's something we provide. We can be partners with them, but it isn't, what I find often is people will say, well, why didn't they tell us? Well, wait a minute now. They're sick in bed. A patient confers a certain amount of status, and it means I need help. So what can you do? I can tell you a bunch of things you could do. You could be really clear about the wants and needs of the patient. You could, I'd say, ask about every single medication. Okay, have the patients always be aware of their medications if they can be. My mother will tell you she's on a pink and a blue and a yellow. You know, not so helpful, but you might say what for, and you'll learn. So this notion of sitting by the bedside watching your loved one, well, I understand that. It still won't prevent everything. You need to come in with all of the knowledge that you have, what's planned, and every day, what's the plan of care? And you want to be driving to getting that loved one out of the hospital as soon as possible. As soon as possible. So, because it's a place for sick people. So get them out. Really. So you ask this, what's it going to take for day one, what's it going to take to get my husband home? And if I don't hear outcomes, if they say he's going to ambulate, how long? I mean it. This is what daily goals look like. The patient is going to walk to the end of the corridor and back. That's a goal. Ambulation, no goal. Drinking, no. What, a sip? 3 gallons? I don't know. What's a daily goal for my patient today, for my husband? When's this coming out? When is this going to happen? And help them understand the power of how much by when, every day. And then, you know what? Your husband can only make it down the hall and he can't turn around. We have to go get a wheelchair. Nothing. So their prediction was off. All there is learning in that. But without a goal, everybody interprets what ambulation looks like. Maybe it's sitting in the chair. I don't even know why you call it ambulation. Why don't you just call it up and walking? Sitting in the chair. Or maybe it's getting up to go to the bathroom yourself. What does that mean? And believe me, that's how variable our own individual assessments of what walking looks like. Because when I have people who say this to me, that we do talk about daily goals for the patient. And yet, I did this, I pulled the doctor, the nurse, and the pharmacist aside after they'd just been into a patient's room, and I said, what's the goal for the patient today? And the doctor said, well, that kind of wet breath sounds, I want to dry him out. Everyone understand what I mean by that, dry him out? Yeah, okay. So you want to dump some fluid, right? So I said, okay, so what's your goal? Well, dry him out. Oh, come on. I finally got him to say 2 liters by 2 or call me. That's what you want. Okay, now I know what diuresis looks like today. I asked the nurse. She did not have that definition, and neither did the pharmacist. They all had the goal of diuresis. Not one of them agreed on what that looked like. So how can you say? So when the doctor comes up at 2 and finds they're only down 1 liter, what's he going to say? What about this didn't you understand? Or, obviously, we didn't have a shared goal. I'm disappointed. Well, of course he is. But we never talked about it. That's what daily goals look like. How much by when for my husband today, and what's it going to take to get home? And you drive that from day 1, and maybe even before they go in. Get them out of the hospital. I'm happy to talk to you personally. Yeah, Vibeke.
Oh, thank you, Carol. I just want to comment on one of the answers you gave earlier, because I had a reflection. You didn't want to post what was the most important issue to address, but I think working together with you for 2 years in 5 hospitals in Denmark, we learned that having daily data concerning the patients we have in the bed, so we know how many patients have a pressure ulcer, or did we give a pressure ulcer while they were here. That is what really drives the improvement. Both
You're
for
so right, Vibeke.
And the CEOs. So.
Yeah, what she said. Daily data. You can't change what you don't know. You cannot improve what you don't know. So build that data system, face reality, and build a learning system to improve and learn from one another. So thank you. It's been great.